Welcome, everyone. We're just waiting a moment as people join us. Please, while we wait, take a moment to introduce yourself in the chat and to access the interpretation feature if you would like that. All right, Emily, I think we can go to the next slide. Welcome, everyone. I know people are still joining, but we'll go ahead and get started. I'd like to welcome you all to today's webinar, which is focused on advancing measurement of the quality of HIP implementation with a focus on two HIPs, community health workers and pharmacies and drug shops. Next slide, please. My name is Trinity Zan. I am the Deputy Director for Research Utilization on the Research for Scalable Solutions project, and I am with FHI 360. I'll be the overall facilitator or MC today. We're really excited for today's webinar. Next slide, please, which I'll tell you a little bit more about. This is the second in a series. Some of you may have joined us back in May when we were touching on a similar but slightly different topic. So the overall goal of this webinar series is really to support systematic and harmonized measurement related to HIPs. In May, we were focused on measuring scale and reach of HIPs, primarily through routine data. And then in this series, yesterday and today, we're focusing on measuring the quality of HIP implementation. We have a couple of objectives in this for today. We really want to share some tools and approaches for measuring the quality of HIP implementation, which would be new to most of you, and then really create some space to discuss whether and how these approaches and tools are feasible and useful and relevant to you all across different implementation contexts. And what we hope we'll get out of this process with you all is a set of considerations for using these tools and really some next steps specifically to agree on their contents and utility and how to promote their use. So with that, I'd like to hopefully introduce our next speaker. Oh, I forgot. Thank you. Just so that we're kind of all in the same frame of mind, we are camping today's discussion with two particular HIPs in mind. Those are community health workers and pharmacies and drug shops. If you were with us yesterday, we were talking about immediate postpartum family planning and post-abortion family planning. So now we have two different HIPs in mind, ones that are much more based at the community level. The definitions are here for you to see if you're not familiar with those. But while the tools can have utility and applicability conceptually to multiple HIPs, we'll actually be sharing examples of how they have been used to measure the quality of implementation of these two HIPs in particular. Okay, next slide. So I'm extremely honored and pleased to introduce our next speaker. In fact, here with us through a recording, not live, but we're very honored to have Dr. Robert Lucien Jean-Claude Kargougou, who is the Honorable Minister of Public Health and Hygiene in Burkina Faso, who provided some opening remarks to us. So we will go ahead and listen to those now.
Mesdames et Messieurs les membres du comité de planification mondiale distingués participants, je voudrais au nom du gouvernement du Burkina Faso féliciter et saluer l'organisation des séries de webinaires sur les pratiques à haut impact de la planification familiale. Je voudrais mentionner que depuis quelques années, mon pays, le Burkina Faso, est confronté à une crise sécuritaire et humanitaire sans précédent du fait des attaques terroristes, ce qui compromet quelque peu la continuité des services essentiels de santé et de nutrition. Pour faire face à cette situation, le ministère de la Santé et de l'Hygiène publique, dans le souci de rendre disponibles les soins essentiels de santé et de nutrition, met l'accent sur le renforcement des soins de santé primaires avec un focus sur la santé communautaire et l'auto-prise en charge. À ce titre, nous avons revu un certain texte législatif et réglementaire pour faciliter la mise en œuvre de la délégation des tâches au niveau des... Je voudrais mentionner aussi la prise d'un certain nombre de décisions politiques ambitieuses, notamment la gratuité des soins pour les femmes et les enfants de moins de 5 ans, mais aussi la gratuité de la planification familiale. Et tout cela est financé à hauteur de 50 millions de dollars chaque année par le budget de l'État. Je mentionne aussi le recrutement de 32 000 agents de santé à base communautaire au niveau des zones à fort défi sécuritaire, mais aussi au niveau des zones périurbaines des grandes villes. La délégation des tâches dans le domaine de la planification familiale au niveau communautaire avec les agents de santé communautaires, mais aussi les agents de santé à base communautaire, est une réalité palpable au Burkina Faso et a permis de booster les indicateurs de la planification familiale. En perspective, mesdames et messieurs, nous souhaitons au Burkina Faso étendre la délégation des tâches aux dépôts et officines pharmaceutiques privées pour l'offre de services de planification familiale, poursuivre la digitalisation des interventions au niveau communautaire et utiliser les outils de mesure de la qualité des interventions à haut impact. Je vous remercie.
Excellent. That was such a treat to hear directly from the Minister of Health about the engagements and priorities related to HIPs in that country and the links to measurement. So we thank him very much for that. This is just a snapshot of the agenda. Hopefully you received that, so I won't spend a lot of time here, but we have a couple of polls that we wanted to launch. For those of you who were with us yesterday, they are the same questions, but that's okay. We have a different makeup of people today. So we'll go ahead and launch the first question. Ooh, not this one. Sorry, Sarah. This was about the country. Where are you connecting from and what type of organization? If we have those on hand. If not, no problem. In the meantime, I will remind you to please introduce yourself in the chat and to access the interpretation services using the instructions that you see there. We do, as you saw, have speakers who are speaking in a range of languages. Excellent. So the first question is, where are you connecting from? And if you could please select your region: North and Central America and the Caribbean, South America, Europe, Africa, or Asia and Asia Pacific. And we'll see who all we have in today's room. Excellent. So we have 42% from North and Central America and the Caribbean, followed in second place by Africa at 30% and Asia and Asia Pacific in third place. Excellent. And our next question is about what type of organization you represent: a Ministry of Health, a donor, an international NGO, a national or local NGO, or other, which could be academia, for-profit institution? So we'll take a moment to answer that question. Great. So we have about half of us from international NGOs, 16% from national and local NGOs. That's great. Followed by our other categories. Thank you. And I think we have one last question, which is to know how many of you participated in yesterday's webinar and how many are fresh. So if you could answer the question, did you participate in the previous day's session? Yes or no? And the big reveal, yes, 70% of you. Well, thank you so much for coming back. We really appreciate it. A lot of today's content is similar, but also has a different take. As I mentioned, we'll be looking specifically at how tools for measuring quality of HIP implementation have been applied, in this case to community health workers, but we'll also have some reflections related to pharmacies and drug shops. And we're very much looking forward to your participation. So with that, I have a couple more slides and then we'll set the stage. So if we could go to the next slide. I just want to acknowledge all of the people who have been a part of this process. It has been highly collaborative across many institutions, including implementing partners, donors, and conveners. Next slide, please. And in particular, we put into place a planning committee to help organize this entire webinar series. And we're extremely grateful to every one of you for your valuable contributions. Next slide, please. So now I'd like to introduce Ms. Olenike Adedeji, Family Planning Program Specialist at UNFPA, who's going to help us set the stage and have some common frame of reference for the rest of the discussion. So over to you, Nike.
Thank you so much, Trinity. And good morning, good afternoon, or good evening, wherever you may be in the world today. Thank you again for joining this global convening on advancing measurements of high impact practices for family planning. Like Trinity just provided information to us that yesterday we focused on the quality of implementation for immediate postpartum family planning and post-abortion family planning. And today, our focus will be on the community health workers and the pharmacy drug stores. Let's go to the next slide, which is going to help us define quality. What do we mean by quality of implementation? And just like you answered this question yesterday, if you were here yesterday, or if you were not here yesterday, go ahead and select in the pool, which should be showing on your screen right now. There are two questions. The first one is, which of these do you consider aspects of quality for family planning that could be measured? So you can select as many as you think applies. And when you're done with the first question, you go to the second question, which says, which of these do you consider levels of quality of family planning that could be measured? It's also a multiple choice question, so you can select as many as applies. And when you click, you submit so that we can all get a look at the responses from everyone. Excellent. So we see that majority of you have selected all the options under the aspects of quality of family planning that can be measured: choice of contraceptive methods, information exchange with clients, technical competence of providers, interpersonal relations, follow-up and continuity mechanisms, and constellation of services. or co-location of services. And the second one, majority have also selected levels of quality of family planning that could be measured as structure of the program, client interactions, and outcomes of care. And you are all very correct. All these domains are can be measured. Next slide, please. So in order to structure our conversations today, we felt there's a need for us to outline and help you understand the framework that we have used for this series of webinars, and in particular for the one for today, to talk about the quality of implementation of the high impact practices for family planning. And this is drawn from this particular framework that defines the quality of implementation across 3 levels. One is the structural quality of implementation, which looks at issues like policy intention, things like readiness to provide services, etc. And we will be focusing in this particular webinar series on the structural dimensions of quality, which focuses on things like the necessary resources and inputs and structures that are put in place in order to be able to implement a particular family planning high impact practice. Or and we define our quality in this aspect in the next few slides. When you come to see, we're talking about fidelity to the model. That is whether the HIP is implemented as intended, because the high impact practices have been designed to follow a particular sequence and to follow certain components. So the idea of quality in this case, in terms of structural definition of quality, is to see whether there's a fidelity to that model or compliance to those to that model. The second dimension of quality is the service giving process, in which case you also be looking at client-provider interaction. That is not the focus of this particular session, but we understand that there are other dimensions of quality which might not be discussed during this particular webinar, but we're not going to exclude them from the conversations we're going to have in the group discussions later. The third dimension is the outcome of the care, which focuses on things like client satisfaction, client knowledge, and client behavior. So next slide, please. So we will now launch a word poll, and you can go to the chat box. You will find the link there. That will take you to the Menti meter. You can also just go to menti.com and use the code that is on the screen. And you type in one or more words that describes quality of, or why measuring of quality of HIPs is important. Why do you think the quality of measuring of HIPs implementation is important? You can use phrases, you can use words to describe why you think this is important. You can do it on your laptop. You can also do it on your phone. And we'll just wait for a few minutes for your inputs to come in. Better outcomes, getting it right, success, precision. Women do deserve it. Yeah. To document success and fail. Confirmation, feedback, fidelity, evidence, standards, accountability, course correction. Keep it coming, keep it coming. Okay. Performance, client satisfaction, improved care, big learning space, saves lives. We can do it. Okay, getting it right. Thank you so much for sharing your perspectives on why it's important for us to measure the quality of implementation of the high impact practices. Now, just to reinforce the fact that there are no existing frameworks on what makes a high impact practice in terms of measurement. So there's little guidance and a few tools available to assess quality of implementation. And that is the reason why some of this work was commissioned, to try to understand the measurements of the high impact practice all the more. Next slide. So in the course of this webinar, we will take a look at two key approaches. The first one is the D4I self-assessment checklist, which is actually a qualitative self-assessment checklist for program managers. And this has been used in Bangladesh and in Tanzania. And the first two approaches are the ones we're going to focus on in this webinar. The third one I will speak to in just a minute. So the R4S SMART-HIP approach is a more quantitative approach, and it uses survey to collect data at points of service, such as health facilities, maternities, and other places where family planning services are provided. And this has been applied in 5 countries. So you will hear from those who have implemented those approaches about the experience and the results from using those tools. But you might also have been familiar, or you might have heard about the WHO bottleneck analysis, which has also been going on in a number of countries. I think at the moment, probably about 17 or 20 of those countries spread across the world have been implementing the WHO bottleneck analysis. Now, this is a more qualitative approach to understanding the bottlenecks to scale up of the evidence-based practices and high impact practices. And the data that comes from the bottleneck analysis also helps to understand the implementation of the high impact practices, but it does not specifically assess the structural dimension of implementation and quality in the way that the other two tools, that's the D4I self-assessment checklist and the R4S SMART-HIPs readiness assessment does. So we will take a look at these data in the next few minutes. And we hope that the data that comes from all these tools will be useful for all of us to examine how we implement the high impact practices in our countries or in our programs. And we're going to spend the rest of the day hearing a lot about these tools. And we hope that you'll be able to contribute during the discussions to lend your own experience in how you have measured quality for high impact practices or family planning in general. Next slide. So many of you gave a lot of good reasons why the measuring of the high impact practice implementation is important. And from that word cloud, we had a lot of words like course correction, like the women deserve it, because we're talking about standards and so on. Yeah. So we do need to have standardized measures. And at the same time, we want to be sure that there's a right balance between standardization and contextualization. And I will explain that in a minute. So having the key implementation components in their related measures can be thought of as somewhat of a recipe. So someone gives you a recipe to make your maybe favorite chocolate cake, so to speak. And if we look at the HIP from that perspective, then it means you should be able to follow the processes you are given, and you come out with an excellent cake, right? With all the right ingredients. So if we take that same perspective to the high impact practices, These have been some guidance on how to reach your expected outcome. And we want to make sure that you are able to follow the processes as outlined in those high impact practices. That would be the standardization. But we also understand that countries are not the same. And even within countries, there are different regions. And there might be different needs for contextualization depending on where you are in the world. So as we have standardization on one hand, we also have contextualization, because we understand that there's a no one size fits all system, and documenting those contextualization is also important, because we then learn from each other about what are those changes we made to those guidance and norms, and still are able to reach our objectives at the end of the day. So as we move through the remaining parts of this presentation today and the discussions we're going to have later, we want you to keep this in mind, and we want you also to share your thoughts about issues around standardization and contextualization in the group work. Next slide, please. So in summary, I know that Trinity already told us about the objectives of the discussion and the webinar. But just to reiterate that we hope that at the end of the webinar today, you walk away with an understanding of why measuring the quality of the HIPs implementation is important and useful, and that you understand the framework and the tools that are being made available to measure the quality of HIPs implementation, and that you are able to provide ideas about how to apply these tools in your own context, and maybe tell us what else you think we need to do when we are using these tools in the field. So we do appreciate your feedback. We appreciate your knowledge and understanding, which is quite important to us, to make sure that you are able to use the tools that are being provided today, and that these approaches are also useful for you to measure the quality of implementation of high impact practices in your countries. So at this point, I think I need to hand over back to Trinity. Thank you so much, and have a wonderful time in the discussions later today. Over.
Thank you, Nike. Thank you very much. And thank you for speaking slowly. I forgot to remind all of our presenters to please speak slowly so that our interpreters can do their job well. So with that kind of common framework and language, I'll now introduce our next speaker, who will add on to that common understanding by telling us a little bit more about these key implementation components that really form the foundation or the starting point for this measurement process. So I'd like to introduce Dr. Jean-Christophe Fotso, who's the founder and executive director of EVIDAF. Over to you, JC.
Thank you very much, Trinity, and good morning or good afternoon, wherever you may be. As Trinity has said, I would like to take a few minutes to sort of continue the stage setting, taking from where Nikki left, with this time a focus on key implementation component. You may remember that earlier in her presentation, she gave, based on the framework that we are adopting here, she gave a definition of what we mean here by quality of implementation, which I quote, the extent to which a HIP is implemented in accordance with key implementation component. So central to what we are doing today is the common understanding of what we mean by key implementation component. So a brief of context here. I think this is familiar to most of us here. You know, high impact practices are a set of evidence-based practices that have been vetted by experts in different fields, with the goal, ultimate goal, really to have programs focus their resources for greater impact. And as you could imagine, for this to happen, for us, for the community of practice to leverage this sort of evidence-based intervention and capture what Nick referred to earlier as fidelity, that's what we want to measure. Are we really faithful to what we are supposed to do? We've got to identify sort of a set of essential ingredients, I like the word recipe, or core elements that really characterize each HIP. So that, you know, from Burkina Faso to Nigeria to Niger to Nepal to Mozambique and, you know, across the world, we have a common understanding of what we mean by, let's say, community health worker. Nikki touched on this. I would just reemphasize, truly context does matter. I think I like the way we all agree, no one size fits all. You know, it's something that we don't want to sort of embrace. Still, we need to sort of agree on a sort of common set of elements that we could be used, you know, across countries and across contexts. She also mentioned context does matter, and Nikki also mentioned earlier that there is in fact no clear or guidance on what should be included as part of a HIP. So basically, this project is sort of advancing the field by putting forward some, you know, some element for consideration moving forward. Next slide, please. So we have to start somewhere. Basically, different projects work together, sharing their experience to come up with the key implementation component related to the HIPs, the two HIPs that we are discussing today, but two others. On the one hand, you can see it in the upper part of the left side, the research for scalable solution R4S and the data for impact D4I teams work together. The focus was on supporting measurement of quality. You can see here the 5 HIPs that were their focus, CHW and PDS, but also IPPFP, PFP, and mobile outreach. On the other hand, and you can see it at the bottom of your slide, the Challenge Initiative TCI project also, you know, put forward some thought, this time with focus on providing implementation guidance. Again, you can see the HIPs overlap to some greater extent. For example, the TCI has a focus on family planning, immunization integration, and the R4S and D4I didn't have that in their focus. After that, both groups come together with support from USAID and from the Gates Foundation to harmonize the key implementation component for the 4 HIPs that they had in common. And those are listed here: community health workers, immediate postpartum family planning, pharmacy and drug shops, and mobile outreach. Next. So the final set of key implementation components that were derived from this group are listed in a brief that you can see on the right part of your screen. Again, these are sort of high-level components that the team believes should be included in each of the 4 HIPs that are targeted here. This can be viewed as a package to be used as a whole, not in part. Again, that way we ensure that across the country, across the context, we have something in common that could be used as a reference point to you know, sort of to evaluate, not only to evaluate the quality of implementation, but even to evaluate the outcomes. Next. So in this slide, we summarize the themes covered under these 4 HIPs. You can see 10 components or themes, you know, in the first column, and then you can see to which HIPs they apply. All 4 HIPs, as you can see, for example, had components related to method, equipment, and supplies. the third on your table. Training was also common to all four. Monitoring, likewise, is coming to all four HIPs, and finally, structured linkages. At the other extreme, you can see a number of components that only applies to one HIP, the first one, community assessment and engagement, or the last but one, leadership. And there is also another HIPs in the middle, supervision, which concern two HIPs, CHWs and PDS. Next. Maybe just to further illustrate what we have discussed earlier to the CHW, you may have seen that, in the CHW column, we had 5 boxes ticked. These are the 5 here: method, equipment and supply, training, supervision, monitoring, structural linkages. So in the second column, we are trying to further explain what we mean by method, equipment and supply in the context of CHW. Basically, to ensure that CHWs, as you can see, have the necessary supplies, equipment, method, and communication material to fulfill their roles. I won't read the others. You can read it by yourself. And again, I'm sure Trinity will be sharing the brief so that we can get additional detail. I think this ends my presentation, and then I will hand over to you, Trinity. Thank you.
Thank you, JC. So as he mentioned, I dropped some links into the chat. The document that lists key implementation components, as well as a brief that summarizes and aligned. Those 2 briefs are available, and take a look. Oh, are you all hearing me now?
Yes.
Somebody let me know if they're hearing me.
Yeah, we're hearing you.
Okay, sorry, I got a message. My internet was bad. Great. So with those foundational concepts in mind, now we're moving into a discussion of these 2 tools that are applying the concept of structural quality and the use of those key implementation components to then measure implementation. So we have 2 presentations, as noted before. First, we will hear from Dr. Susan Petrick, who is the Data for Impact Partner Lead at ICF. She was unable to join us in person, but she has a recorded presentation that we will listen to shortly, and then that will be followed by Dr. Aurélie Bruni, who is the Deputy Director. She's focused on research for the R4S project and also the Director for the SMART-HIPs project, and she will be presenting on that quantitative tool. So first, we will listen to Susan.
Good day, everyone. I hope you all are doing well. My name is Susan Petrick. I'm going to give a presentation based on a HIPs assessment we undertook through the Data for Impact, our D4I project. The bulk of this presentation is focused on the methodology we used, including the vision that this methodology is well suited for assessing quality of implementation and could be easily replicated. Ours was a 2-country assessment with focus on 7 USAID funded projects. On the left, I have noted the 7 projects and the lead implementing organizations. The D4I assessment covered 3 service delivery HIPs. For this presentation, we will focus only on the community health worker HIP. The D4I assessment was a collaborative effort. In particular, I led the assessment, and it was an activity under the Data for Impact project. I worked closely with a partner in Bangladesh, the Capacity Building Services Group, as well as a partner in Tanzania, the Center for Research, Mentorship, and Support. The main aim of this presentation is to present the assessment methodology we used, which basically is a facilitated self-assessment methodology. We convened small groups from each project and administered a core component checklist. We published a 3-page brief which provides an overview of the methodology, including some suggestions for replicating the methodology. A key aspect of the methodology was that it was a space for a small team from the project to come together and think through each core component and discuss to what extent the core component is being implemented. The D4I assessment team facilitated the discussion. As a quick overview, with the D4I assessment, the term quality of implementation is defined as the extent to which a HIP is implemented in accordance with key implementation components, or core components. It is important to remember that our use of quality is not in relation to quality of any given health service. Again, here, quality refers to if implementation is undertaken per established guidance or standards. Further, the assessment used core components as a framework and a way to look at policies, skills, readiness at the service delivery level, resources, and quality control procedures. The key features for D4I was to use a core component checklist to assess and rank the implementation of each core component on a scale of 1 to 4. This slide presents the 7 core components for the community health worker HIP. As you can see, the core components try to convey a set of standards for implementing a CHW program. Thus, in turn, a core component assessment can be carried out to understand the extent a project or a country program is implementing the individual core components and, in turn, the HIP overall. The idea with the core components is that they lay out what makes a HIP a HIP. For any core component, the logic is that if this is not done, then the HIP overall is not being implemented to its fullest and according to what are viewed as the implementation guidance. Our core component checklist was administered through facilitated small group discussions and self-assessment. Each project determined the size and makeup of the small group. Generally, the participants were mid to senior level management, mural, and technical staff members from the project. The end goal of the group discussions was for the participants to agree on a ranking for each core component using a 1 to 4 scale. The lowest ranking of 1 is defined as the core component is being implemented partially and or in limited ways. The highest ranking of 4 is defined as the core component has always been or is being implemented fully with indicators to track. Just to make one small methodological distinction, I have used the terms facilitated self-assessment and small group discussion. I have purposely avoided the term focus group discussion. This is a quality of implementation assessment with a facilitator guiding a small group to determine a ranking. This is a unique and specific type of group discussion and different than how a focus group discussion would be approached in, for example, a qualitative study. To further help convey how the core component checklist was administered, on the right is the data collection tool that was used by the facilitator. This is the one-page tool for the CHW core component 1. The tool lays out the procedure to administer the checklist. To begin, the discussion is a yes-no question. Does the project implement the core component? Next, the facilitator poses several probing questions. These have the orange box around them. At the bottom of the tool is a space to record the rankings from the project team and the assessment team. Here, the probing questions for core components 2 to 7 for the community health worker HIP are noted. This is to emphasize that the probing questions are tailored to each core component. Because the assessment is facilitative and qualitative oriented, the aim with the probing questions is for them to prompt discussion among the project team, and specifically discussion about if each core component is being implemented. The discussion is being facilitated with the facilitator guiding the group to establish a rank for each core component. Both the rank and what is said during the discussion were considered data. I wanted to also touch on some of the findings, as this can help provide clarity on the methodology and how the assessment was carried out. For this assessment, there were two main sets of people involved, the project team and the assessment team. The project team was the participants for the facilitated self-assessment of core components and HIP implementation. They agreed on a rank for each core component with discussion facilitated by the assessment team. As noted in the table on the left, the size of the project team groups range from 3 to 10 people. Also in the table, the number of male and female participants is noted. The assessment team facilitated the discussion among the project team. Also, after the session, the assessment team agreed on a rank for each core component based on a review of the notes and recording of the session. In both Bangladesh and Tanzania, the core component checklist work was carried out virtually. This table shows the instances of ranks for each of the 7 CHW core components. The instances of 1 or 2 rankings for both the project teams and the assessment teams is presented in comparison to the instances of 3 or 4 rankings, the higher rankings, for both the project teams and the assessment teams. Given the higher number of rankings for 3 and 4, this suggests that the perception among the project team is that the core components are being implemented. Where you see the rankings of 1 and 2, these are places where the project teams noted there may be challenges with implementing the core components. This table shows the results of the core component checklist exercise for the community health worker HIP for each country, including the average rankings from the project teams and the ranking from the assessment team. The highest rankings are shaded in orange, and the lowest rankings are shaded in light green. Community health worker programs. For example, the higher rankings with core component 3 and 4 make sense. These are centrally what community health workers do. They provide commodities, services, and behavior change. The lower rankings with core components 6 and 7 also seem to make sense. Integrating community health workers into the health system is often not the mandate of a USAID project, or even within their control. And while there is generally considerable community engagement with community health worker programs, often projects rely on community health workers from previous projects, so there isn't necessarily a recruitment process per se. In bringing this presentation to a close, I wanted to touch on a couple of high-level conclusions. First, results from the ranking exercise indicate quality of implementation is strong. However, many of the points raised during the core component checklist exercise signal a more complicated landscape with numerous challenges reported. In addition, the HIP definition and core components created for this assessment are each very specialized. The projects appear to not implement to the level of specificity in these definitions. Second, as has been highlighted, the assessment was qualitative oriented. This methodology had dual focus. It was both a way to collect information for an assessment, but also it served as a way for the project teams to reflect on implementation. Indeed, the assessment was well received by the project teams. They indicated it was a useful exercise. In particular, the assessment helped the projects to learn more about what the HIPs are and how they are defined. Also, the core component checklist exercise exposed the projects to assessing against implementation guidance, which is very different from monitoring in relation to input and output indicators. A final and important high-level conclusion is that replicating this methodology would be easy. Any donor-funded project or national program could administer a core component checklist for the CHW HIP or any of the other HIPs. There's ample space to tailor the methodology. A couple of pieces of advice I would offer for anyone wanting to replicate. First, take time to think through the options. There are not necessarily wrong options, whether there are choices. For example, the facilitator could be from the project or the program team, or also the facilitator could be external to the project or program. The rankings could be from the project or program team and the assessment team, or also the rankings could be just from the project or program team. In making choices, it is important to bear in mind the pros and cons of the methodology. This was a low-cost exercise, and it's something that a project or a program could undertake themselves. But even as a low-cost undertaking, there are still concrete and actionable insights that can be gathered. It is important to think through the ways that possibly the views across the project teams might vary within the small group discussion. And also there likely will be hesitancy for project teams to assign lower rankings. Lastly, it's important to remember that this was less an exact measure in a quantitative sense of quality of implementation and more an assessment of quality of implementation in a qualitative sense. Here I have provided some links to the various reports and briefs from the assessment. And that brings the presentation to an end. Thanks so much for listening. I'm so sorry that I was not able to be with you live, but I hope that the rest of the meeting goes well. Thanks so much. Good day, everyone.
A big thank you to Susan for providing that presentation remotely, which really illustrated how D4I took those key implementation components and put them into the format of a checklist that could be used qualitatively to self-assess within a project or a program how they are doing with implementation. So now we'll hear from Aurélie about a quantitative survey approach at the point of service. So over to you, Aurélie.
Thank you, Trinity, and good morning, good afternoon, or good evening. So this presentation will introduce measures for quality of implementation for CHWs and pharmacies and drug shops that we developed and tested under the R4S project funded by USAID and under SMART-HIPs, which is funded by the the Bill and Melinda Gates Foundation. So today we'll cover the process that we followed to arrive at the measures and the measures themselves. This effort has involved a lot of organizations and individuals, so I'd like to acknowledge FHI 360, AVDAF, Makerere University School of Public Health, and Save the Children, as well as our partners AKENA in Nigeria, CRESS in Nepal, ISSP in Burkina Faso, PACT in Mozambique, and the Global Planning Committee that Trinity mentioned earlier today. Next, please. So if you were with us yesterday, and I know many of you were, the overview will sound familiar. So I'm sorry if it is a little bit repetitive, but I know that listening to Susan's presentation today, I actually picked up on a few new things. So I hope this might be the same for you. And the second part of the presentation on the measures themselves will be different, since we have different measures for these two HIPs than we did for IPPFP and PAFP. So for those of you joining us for the first time today, the definition of quality at the top in the purple box is aligned with what Nikkei started us with today. Our goal was to reach consensus on a set of measures that we could operationalize through surveys to assess readiness to offer services at point of service, meaning where the CHWs or the pharmacies or the drug shops are. You can see the process in the middle. The starting point was the key implementation components for CHWs and pharmacies and drug shops, but those are fairly high level. So we developed readiness standards that are a more concrete expression of what needs to be in place at point of service. And then we align the survey questionnaires with this. And for those, the surveys were survey questionnaires for community health workers, and then a separate one for drug shop operators or pharmacists. Next. So in this case, the measures were tested and developed through a 3-country assessment. And the countries were Nepal, Uganda, and Nigeria. And so for each of the 2 HIPs, we conducted surveys in a subset of geographies from 2 countries. For CHWs, Nepal and Uganda. For pharmacies and drug shops, Uganda and Nigeria. Next. Here you can see the number of surveys that were completed in each country. And as we get into the measures, we will share some results, primarily because those were meant to test whether the measures are relevant and viable for capturing quality, rather than to provide a picture of quality in any of the countries at this time. So keep in mind when you see the results that this is more about the process of developing the measures and that the results are not nationally representative and that we cannot compare them across countries. As many of you know, there are sometimes different cadres of CHWs or different private sector actors in the pharmacies and drug shop sector within a country. And we generally recommend selecting different samples for these different cadres as relevant based on the context. So one example for our assessment was for pharmacies and drug shops in Nigeria. We include a sample of PPMVs, patent and proprietary medicine vendors, and then a separate sample of community pharmacists because the responsibilities and expectations of these two cadres are different. Next. So this process, again, may be familiar if you were with us yesterday, but the process we used to arrive at the measure was iterative. Starting on the left side of the slide, we derived an initial set of key implementation components that served as the framework to develop the survey questions, the initial measures, and the initial scoring system. And then if you look to the right of the slide, we used a set of considerations to revise the measures along the way. So the first one ties to what JC talked about earlier today, which is that the key implementation components were initially developed by different projects as separate efforts, and then they were harmonized. So we did some work to better align with the harmonized version of the key implementation components. The second piece was based on reviewing and discussing the results through country validation meetings, and then through a workshop with the Global Planning Committee that we introduced earlier today. And the goal of that was to make final decision on the measures. And for those final decisions, we were considering primarily 2 points that you can see at the bottom of the slide. The first one where when a standard had consistently high or low scores, we wanted to be deliberate in making sure that the information we were capturing was still useful, as opposed to it being a sign that we were not asking the right questions. And then the second piece was about balancing, having commonality across the countries and contextualizing the measures for each implementation context and where that was appropriate and where that was not necessary. Next. So here is an overview of the amount and type of data involved. The colored boxes in the middle are the key implementation components, and then the lighter boxes on each side are the associated number of questions for CHWs on the left and for pharmacies and drug shops on the right. And there are some illustrative questions at the bottom, and it's a survey format. Looking across the key implementation components, we had a total of 16 questions for the CHW survey and 17 for the questionnaire for pharmacies and drug shops. Next. So there are some differences between the measures for the two HIPs, but overall they are fairly similar. So in the interest of time and to allow giving the full picture for one HIP, today I'm going to focus on the measure for community health workers. Next. So I'm going to start here with some context and background on the cadre for the assessment in each country. In Nepal, female community health volunteers focus on promotion, and they offer combined oral contraceptives and male condoms. In Uganda, on the right, village health teams consist of 2 male or female volunteers per community, and they offer injectables, pills, condoms, emergency contraception, and the standard day methods. In both countries, CHWs are linked to health facility for reporting and for resupply, and they are expected to participate in monthly review meetings with other CHWs at the health facility. Next. So again, if you were with us yesterday, the format for the rest of the presentation will feel familiar. This initial table is an overview of the key implementation components for community health workers, the associated readiness standards, and then the proportion of CHWs meeting each standard for the sample in each country. Similar to what we saw for IPPFP and PAFP, again, the results are meant to test whether the measures are viable and relevant and to illustrate the information that's generated, but they don't provide an accurate representation of quality of implementation for CHW programs in the two countries at this time. Also, as you may have seen for other HIPs yesterday, there is variation in the results across the components. Some of the standards are very high, and in many cases, they were not met. But you will see, I hope, through the rest of the presentation, that looking at the different elements that go into a standard can provide useful information and allow for an understanding of the reason why a standard may not be met in a particular context, and the reasons are not necessarily the same. Next. So starting with the first key implementation component, that is choice. At the top of the slide, in the purple box, you can see the readiness standard. And then the next box with the red frame shows the different elements that go into the measures. But for choice, the standard is considered to be met if the community health workers have counseling tools or job aids, and if they have the methods that they are authorized to distribute. And as we did for IPPFP and PAFP, the standard is contextualized based on country guidance on what methods community health workers are authorized to provide. If you were with us yesterday, you might recall that for IPPFP and PAFP, the requirement for this standard was that facilities have all the methods that they are authorized to provide. For CHWs, and that's the same for pharmacies and drug shops, based on the discussions that we had with country and global stakeholders, there was agreement that this was too much, given that those actors are at the last mile of the supply chain. So instead, this element of the standard is considered to be met if CHWs have at least one product from each of several main categories as applicable based on country guidance. So for that, we looked at two versions. The first one is what's referred to as minimum package, and that means having at least one type of injectable, one type of pills, and male condoms, if these methods are authorized. And then the second layer is the same minimum package with the addition of at least one other methods if CHWs are authorized to provide more than the three methods that I just mentioned. Next. So here, the table shows the proportion of CHWs that meet the standard. The first row represents the proportions that have counseling tools and the minimum package, so at least one injectable, one pill, and male condoms as authorized. And the second row is the same with the addition of having at least one other method in stock, and that applies only to Uganda, because in Nepal, the only authorized methods are COCs and male condoms. And then at the bottom of the slide, the bar chart shows the different elements that go into the standard. So for Nepal on the left, Uganda on the right, the yellow is counseling. The next bar is having at least one type of injectable, which applies to Uganda only, then pills, then male condoms, and then again for Uganda only, at least one other method. And it can be useful to look at this to better understand what is behind the results. So if you look at Nepal, you can see that the results are reasonably good for each element, but they go down to 40% when you require having all of them. And for Uganda, the results are strong for counseling tools, injectables, and condoms, but there is a big drop for availability of pills and other methods. Next. The next component is technical competency. For this, the standard is met if CHW reports that they have been trained on each of a series of topics and that they feel confident providing the corresponding services. And the list of topics is in the orange box at the bottom. It is based on country guidance. So the box shows the full list, but you will note that the two last topics on injectables on the right apply only to Uganda and not Nepal because of current country guidance. Next. So if you look at the results in the bar chart that split the results by element, you can see that the proportion of CHWs having been trained on all topics in yellow is higher than the proportion that report feeling confident. In blue, I still can't decide if it's blue or green, which is what you would expect. Next. But again, it is helpful to look at more detailed results to better understand the overall score. So here you can see the results for training at the top for each topic. And then at the bottom, the results for confidence for each topic and each country as applicable. So again, there are fewer topics that apply to Nepal than Uganda, which is why sometimes there is no bar for Nepal. In Uganda, you can see that injectables in the middle bring the results down, both for training and confidence. But it's important to place that in context because the measure required training and confidence both for intramuscular injections and subcutaneous injection. And in reality, service provision for injectables in Uganda is based on training of VHTs, and they may have been trained in one type of injectable or the other based on timing, geographic location. So it might actually be more accurate to look at the results for IAM or SC than at the results combining both. But that's why it's important to look at the detailed results and not only the total scores for interpretation. Next. The next component is supervision. For CHWs, this is based on having both regular supervision and as-needed supportive supervision. Regular supervision is reflected in the first bullet or element of the measure, which is based on CHWs having participated in a supervision or review meeting with their primary supervisor, or having attended a meeting with other CHWs at the health facility in the past 3 months. For as-needed supervision, the second bullet or element of the measure is based on the availability of a mentor or supervisor who can answer questions. And this person can be a mentor or supervisor from the health facility, or they may come from an organization outside of the health facility. And the measure was constructed in the same way across countries. Next. So this was the standard that was most commonly met across both countries. You can see the results are very strong. But in our discussions with stakeholders, we felt that the measure was appropriate and capturing key elements of supervision that need to be in place. So this shows strong performance in both countries, at least for the samples that we looked at, and that's great. Looking at the bar charts, we can glean slightly more information on how each element of the standard was met. So the two blue bars on the right that are for as-needed supervision, the first one indicates the availability of supervisor at the health facility, and the second one, the availability of a supervisor outside of the health facility context. And for both countries, as-needed supervision overwhelmingly comes for the ones that were in our sample from the health facility. So the value of looking at these more detailed results is for countries to decide whether it is sufficient to have the supervision from one source, or whether they would want mechanisms in place to reinforce additional linkages, or if they would expect that more than what the results show. Next. The next component is around referrals. For this, the standard is met if CHWs know where to refer clients for the methods that they do not offer or do not have in stock, and they report using a specific referral mechanism other than verbal referrals. And the measure was again constructed in the same way across countries. Next. So once more here, it's interesting to look at the detailed results to understand the overall score. So if you look at the bar chart, in both countries, CHWs by and large know where to refer, meaning like it's one of the two blue or green colors. In Uganda, they also report using referral mechanisms most of the time, so it's the lighter shade. But in Nepal, the referrals were mostly met, they were mostly verbal in the sample. Next. So the final component is monitoring, and it focuses on 3 elements: documentation of services provided in a register, submission of reports, and then commodity tracking. For documentation of services, the focus was on registers because this typically is the support that provides the basis for reporting. And for reports, it was a simple question on reporting to any authority, and it could be refined, which is what's in the green box at the bottom, based on the frequency of report submission and or requiring to narrow down the specific authorities that the reports are transmitted to. Next. So if you look at the chart at the bottom to see like each of the elements, the first one is reporting, the second, no, sorry, entering the information in registers. The second one is reporting. The third one is monitoring stocks. You can see perfect results for report submission, so the blue-green for the two countries, which is why we were suggesting on the previous slide, potentially strengthening this measure. The other two measures on documenting services and monitoring stocks show more variation, and they appear to be useful as they are. And overall, for both countries, it's monitoring of stocks that was the most challenging in our sample. So next, sorry. These conclude like the list of measures and key implementation components. So this slide provides a summary. The results are mapped to 5 key implementation components. The final tool covers the components through a total of 16 questions. And we recommend that the measures for the first 2 components be contextualized to account for differences in country method mix and guidance on authorized services for community health workers, but that the measure for the 3 other components are the same across countries. Again, there is a lot of room to allow for further discussion and contextualization in interpreting the results when looking at the elements of each standard. As part of the discussion with country and global stakeholders, there is one other topic that came up that's not directly included in the components, but I wanted to note here, and it's proper commodity storage. Next. So to end, it's very similar to what we discussed yesterday. I wanted to share some observations about application of this tool. At the top of the scale, you can see the challenges we encountered, and at the bottom, some of the benefits of this approach. And in terms of challenges, one challenge is having a sampling frame because there are typically no listings of community health workers. And when you go down to facilities, you may not really know what to expect because the number of CHWs linked to a health facility tends to vary across facilities, and you may not know it in advance. Second is the question of conducting standalone surveys, which is a big effort. That came up, I think, in the small group discussions again yesterday. And so we hope to have more discussion on this topic in terms of opportunities for incorporating those questions in existing mechanisms. And also similar to yesterday, defining acceptable quality, meaning the conditions for a standard to be met, is not an easy task. And it's taken a lot of discussion with country and global stakeholders to get to the measures that we are proposing and that we shared today. In terms of benefits, the first one is that, as Nike noted earlier, regular surveys typically do not provide information on CHWs or pharmacies and drug shops. The second is that the key implementation components provide a systematic framework to make sure that we are comprehensive and looking at all the important ingredients that need to go into the recipe that JC described. And then the third is that the way the measures are framed allows for a focus on implementation, including by examining the details of the elements of each standard. Next. So to end, I'm going to take us back to the questions for today. So we've talked about why we may want to measure quality of implementation. The 2 presentations, Susan's and this presentation, hopefully gave some ideas about potential tools. And we're hoping to engage in more discussions around concrete aspects for applying those tools and measure in your country context through the remaining discussions and small groups. Thank you, and back to you, Trinity.
Thank you, Aurélie. As Aurélie joked, for those of you who did join us yesterday, although repetitive, this is some dense material, so I do hope that it may have allowed for additional synapses to click and things to fall into place. We'd like to now move into a section where we listen to those in decision-making positions reflecting on this topic of measuring quality of implementation, thinking through some of the challenges and some of the opportunities that these new tools may offer. So first, I will be inviting Mr. Emeka Okafor, who is the Chief of Party for the Integrate project based at the Society for Family Health in Nigeria. Mr. Okafor is an expert in private sector and family planning, and so he'll be sharing his thoughts on some of the challenges in doing so in the context of pharmacies and drug shops and thoughts on these tools. So over to you, Mr. Okafor.
Good afternoon, everyone. I just would like to use this opportunity to thank the SMART-HIPs group for inviting me to make this presentation. Basically, what I will be doing is just to give a summary of what the project is about, and then share some thoughts around how we think the SMART-HIPs implementation measure can work, and some of the challenges or concerns we have. The project actually is called the Integrate E project, which started as a proof of concept that community pharmacists and patent and proprietary medicine vendors can actually be trained to provide a wider spectrum of family planning and primary healthcare services than they are authorized by law. So essentially, the project set out to produce some evidence that will help policymakers, change policies that will allow for an expanded scope of family planning to be provided across this channel. So we've been able to do that successfully from 2017 to 2021. And that led to a number of policies, including the tax shifting and tax sharing policy, which now allows a cadre of PPMVs called the Tier 2 and Tier 3. That is those who have health background and community pharmacies to provide injectable contraceptives and implants in their outlets. So we are currently in the second phase of our implementation. So I will run you through some of the key implementation components and then some of the thoughts that we have around the SMART-HIPs. Next slide. So like I said, this is just a repetition. The goal of the project in the current phase is to continue to test and integrate service provision and in community pharmacies across 11 states, and also continue to generate further evidence for incremental policy change. So the key objective is to continue to support operating environments that will allow them offer an expanded scope of family planning services, and then also increase access to expanded scope of family planning services and PAC services by women and communities, and then continue to develop a robust implementation science and research agenda that will inform policies and programs. So currently we are looking at 11 states in Nigeria. The current phase of implementation started in 2021 and will end in 2026. So SFH is just the lead partner. We have other partners. We have Population Council, PSN, that's Pharmaceutical Society of Nigeria Foundation, AN Impact, and AXNIVI. Next slide. So in terms of our key implementation components, one of the first things we did look at was to identify and select the PPMVs and community pharmacies. Because again, the PPMVs are not a homogeneous group in Nigeria, there are so many people who have health background or health training prior to becoming PPMVs. So we needed to first of all identify them and then stratify them. So those that do not have health training are regarded as non-health trained PPMVs. And then those that have health training are regarded as health training PPMVs. That's the the CHWs, the nurses, the community health officers, and then, of course, the other group, the community pharmacists. And then after characterizing them, the next thing we did was to also provide some training in terms of the package of services that each of the cadre was expected to provide. For the non-health trained PPMVs, they are only trained on providing the balanced counseling, refill of oral pills, and barrier methods, but they refer on other methods. But for the health-trained PPMVs, they are trained to provide broad family planning services, including balanced counseling services, oral pills, refill, injectable contraceptive implants. However, this category refer for IUD. The same for community pharmacists. They are trained to provide the BCS plus, oral pills, injectable contraceptives, implants, and they also refer on IUD. Then, following the training, there's also a competency certification process, especially for those cadre of providers that are expected to provide LAC, where they are mapped around a primary healthcare center, and then also assigned an FP master trainer who mentors them and makes sure that they achieve some level of competency by way of some number of insertions that are properly supervised before they are allowed to provide it in their outlets. So the same goes for both the health-trained PPMVs and the community pharmacies. But the non-health-trained PPMVs, because they are not expected to provide LAC, they do not go through the competency certification. Then there's also referral for services. So as they are also being trained, they are also mapped around a higher level of care, either a PHC where there is one that is functional, or they are mapped around a general hospitals. So for those services that they either do not have the products for, or they are not trained to provide, they are expected to refer. And then, of course, there's also supportive supervision that happens where either the state is providing some level of support or the program is providing some level of support. And then they also do distribution of IEC materials and job aids to further support them in providing the services that they are trained for. And then finally, there's also a monitoring process that cuts across the 3 cadre of implementation. Next slide. So in terms of how we measure quality or monitor quality now, which is clearly different from what the SMART-HIPs is thinking about, is the fact that the 2 major kind of supervision that happen at the state level or at the community level among this provider is the one is led by the state, called the state-led integrated supportive supervision. Here, what we did was to look at the existing structure for supervision across each state, which is called the PPMVL committee, headed by the directors of pharmaceutical services. So we expanded the membership of that committee to include the family planning state coordinator. Again, because we found out that they really do not have the skills to supervise on FP services. They can only look at, other aspects of supervision, the quality of medicines they are stocking, the storage conditions of medicines and all that, but they do not have requisite skills to supervise for FP. So what we did as a project, because we are looking at sustainability, was to expand that team to include either the RH coordinator of the state or the FP manager of the state. Then the project-led supportive supervision was actually, more constant, done on a monthly basis, looked at how to constantly improve on the quality of services that they render using a checklist that has been developed nationally called the Integrated Supportive Supervision for community pharmacies and patent medicine vendors. So that's actually what the project uses for that supervision. Next slide. So for the SMART-HIPs, we actually think that it would be very useful for implementers like SFH and other implementers who work with the drug shops, because essentially it will also help, the project team look at how the key components are being implemented, across all the different cadres, to what extent the implementation is being achieved. So those are one of the benefits that it will give any project. And then also where there are gaps, it will also throw up those gaps. And then the project can take a decision on what to do to make sure that the implementation is in line with the core components of the project. And then for the PPMVs, the operators themselves, I think it's also help them see how ready they are in terms of providing quality family planning services. Let's take, for instance, if the minimum package for choice for a particular cadre of PPMV is baby condoms and barrier methods, and all you can find is condoms, then that means that in terms of the choice of services available, that provider is not meeting it. So it also helps the provider see where they can improve. And then for us on the project, our concern is, at the end of the day, will this tool be context specific? I have seen the one for CHWs, and I think that if it is context specific, it would make it more usable. Because, for instance, what would be a minimum package for a non-health trained PPMV will definitely be different from the health trained PPMV and also for community pharmacies. So the level of adaptability of the tool is actually what will make it most useful to implementers. Next slide. Then looking at also who to use the tool and how it can be used, I would think that implementers can use the tool. Also, government can use the tool. The only challenge with implementers using the tool, again, is how do you also ensure that they are as objective as possible in assessment and scoring? For instance, if I'm using the tool, how am I sure I'm being very, very objective, in the use of the tool, even though I know at the end of the day, it will make the implementation better and the outcome will be better. So across programs, how do you ensure that implementers, use the tool very objectively, especially when they are the ones scoring and assessing? And then finally, in terms of other partners or government using the tool, I think, again, if I have looked at some components of the tool and I've seen that some of them are already in the existing tools. So it's how this is incorporated into existing tools that will determine for how long this can be used by the relevant bodies. But if it is another entirely different tool, my thought would be that it would be difficult to convince people that are outside the program to be able to pick up the tool and use them. Over.
Thank you so much, Mr. Okafor. That was highly helpful and relevant for the discussions to hear directly from you about how you think different people might use this and what some of those challenges and opportunities would be for each of those use cases. You brought up the need for contextualization, which I'm so happy that you did and remains a part of the conversation. And you brought up the point about how to incorporate this into existing tools and processes and procedures. And that's exactly what we want everyone to be thinking about and what we'd like to hear so that we know how best to package these tools and make them available so that they can be incorporated into those existing mechanisms. So thank you so very much. That was super interesting. Now we will shift to thinking about the community health worker HIP, and we're going to hear from two individuals talking about the same questions. What are the kind of challenges and opportunities I apologize because I'm realizing we did not include our moderator on this mini panel. So I'll introduce Mr. Emeka Nwachukwu, who works at USAID Washington. He will be our moderator for this mini panel, and he will be posing some questions to Mr. Rogers Kagimu, who is the Track 20 M&E officer at the Ministry of Health in Uganda, and to Dr. Jasmine Shrestha, who is a senior consultant OBGYN at the Paro Pakar Maternity and Women's Hospital in Nepal. So Emeka, my apologies once again for leaving you off of this beautiful slide, but we see your face now. So over to you. Thank you. And you're on mute, if you could unmute.
Oh, I'm sorry about that. Thank you, Trinity, and thank you to all participants, to all members of the planning committee for this wonderful meetings we've had yesterday and today. And I want to especially thank panelists, Mr. Rogers Kagimu and Dr. Jasmine Shrestha, from agreeing to participate in this brief discussion. As has been introduced, I'm Emeka Nwachukwu. I work for USAID in the Office of Population and Reproductive Health in Washington, D.C. as Senior Research Advisor, and also as part of the HIPs team responsible for measurement and metrics side of things. And I'm happy to be moderating this brief session with the country counterparts in this meeting. I'm going to ask the two questions that we're going to be considering to both panelists at the same time, and I'll give him some time to respond to them one after the other. The first question is going to go to Dr. Jasmine, and in that question, we are going to be asking her to help us examine how either of the tools, that is the qualitative self-assessment checklist produced by D4I, and all the quantitative point of service survey tool developed by R4S will bring added value to any information needs the national program might have about community health workers implementation. In responding to that, Dr. Jasmine, I will want you to also consider what parts of the tools will have to be contextualized. Remember the presentation we had from Dr. Lanike Adedeji about contextualization of the tools to suit both country and program needs. So how would those tools be contextualized in order to reflect the community health worker strategy of your national program? And then finally, would you kindly consider how these two tools provide complementary information to each other? I will read out the second question for Dr. Rogers so that he will take on right after Dr. Jasmine is done. For Dr. Rogers, we want you to consider what options exist for using either or both tools in Uganda. In answering that question, please consider if there are any existing mechanisms or programs for data collection that could be used. If there is none, who will be best placed to collect the data, and how frequently should this data be collected? And finally, who will review and discuss the data, and with whom will the result be shared and disseminated when they are available? I will yield the floor to Dr. Jasmine Shrestha to take on the first question.
Thank you, Emeka, for allowing me to involve in this question, in this panel. And hi to everyone in this webinar. So regarding the first question, overall, these tools provide insight to look at the FCHW work from technical capacity, commodities availability, and supervision and monitoring of their work. So in Nepal, FCHWs are under Social Security section of Nursing and Social Security Division of Health. So the relevant department of the nursing division can be further coordinated and oriented about these tools for comprehensive monitoring of family planning services through FCHB. In Nepal, community health workers are the female community health volunteers, and they are not from medical background, so they are allowed to provide condoms and pills to not to the new users but the continuous users. And regarding the second question, what part of tools would have to be contextualized in order to reflect the CHW strategy of your national program? Actually, R4A study showed female community health volunteers verbally refer clients to other health facilities, and they do not document those referred cases, and also they do not report to the local health facility. So emphasizing and mandatoring community health workers to provide referral slips to clients during their referral, and that is to be documented in the register and then reported monthly to the local health facility or local health coordinators. FCHB, and another thing is FCHB needs update in the new information of the family planning methods. So refresher training should be provided to them to reinforce their skills. And in Nepal, FCHBs provide, so as they provide only pills and condom, we can train them to provide standard day method also. So regarding the third question, could these two tools provide complementary information? Yes, they do. But in Nepal, HIP study was done by R4S only. But going through the two tools of these two studies, the two components of D4I, that are component number 6, which is engages communities in recruitment and supporting, and other component number 7, formalizing the role of CHWs as part of the health system to recognize their series. These two components are not there in the R4S study, HIP study. But the R4S study tools questionnaires has these components. So if needed, these components can be analyzed from the R4S HIP study. And the other thing is the tools used by D4I HIP study covered more information than R4S HIP study, such as D4I HIP study tools monitor data on FCHV logistics and commodities at both level, health center and district levels to avoid stockout. Whereas R4S study, they did not monitor the monitor data for they have only the data of the local health centers. And another point is that D4I HIP study tools assess FCHB's ability to provide behavior change messages, but R4S HIP study tool didn't assess that one. Thank you.
Thank you so much for this concise presentation. We've heard from you explicitly around community health workers programs as implemented in Nepal, and your opinion on how these assessment tools can be used. You did let us know that community health workers in Nepal that has no medical background provide just condoms.
Yeah.
And I do think, yes, at least condoms. And I'm thinking that there's an opportunity here for a national program for task shifting and training of these people, like we've heard from the SFH program in Nigeria, to provide or to expand their portfolio and their offering in order to expand access to family planning. You also explicitly explained that community health workers referral documentations are in the register and are in turn reported to the regional health managers, which is a very nice practice that should be well exposed and implemented so that we can collect data on whatever services that is being offered. We know, like you've said, that these can be trained to provide other modern methods as allowed by law and enabling policies for their practice. You did explain that the two components of recruitment and formalization of community health worker roles can be analyzed from the RFOS tools, which is included, and this was not included in the D4I study, which is very clearly stated in those studies, because the D4I study is quantitative, is qualitative, and included program implementation, while the RFOS tools is both health facility and provider assessment. It will make sense at this point to combine those tools, possibly if you want to look at all of those components together and gain all the benefits of all the components that were included. I will stop here. Thank you for your input, and go to Dr. Rogers to take on the second question. Thank you so much.
Thank you very much, Dr. Emeka. I want to start off by trying to bring this into more context, where I would say that of late, limited options existed due to the general lack of what should be assessed, how to do it, and possibly why to do it. But as of yesterday, there has been a better and clear understanding to the three questions as to why we need to measure quality. And in that regard, these tools, especially the RFOS tool, can be more replicable and adaptable, given its possible little time it requires in picking the data. I mean the quantitative part of it, which I believe is a good thing. Though it goes ahead to leave out what I believe is very key in terms of quality again, and that is assessing the component of commodity safety. That is something to do with the storage environment, whether it is ideal at the community level. So us leaving out this, I think, is to a disadvantage, especially to other line departments within the ministries of health, for example, the logistics department, who are so much into the availability of these commodities, but also their safety in terms of storage. So the team trying to address this, I think, puts us to an advantage of having this tool not only being owned or used by a family planning program, but probably the department or the programs from the logistics side of it. Also, I want to note that having these tools as standalone, in other words, trying to respond to how they can be used, having them as standalone is likely to pose some kind of implementation challenges for one reason. Most of them, actually, both of them are surveys, and realize that it is expensive to conduct these periodic assessments, especially if they are standalones. Most of the donor support is dwindling in most of our countries, especially Uganda. And so we need to think of options that we can explore to be able to come to integrate these tools. And so going forward, if we are to pick these tools and make them usable, we should think of integrating them in the already existing data collection mechanisms being used by the different programs to come up with abridged versions of the tools that have got a component of quality. That brings me to the second part of my question, where you asked me whether there are any existing mechanisms for data collection that could be used to include these tools. I would say yes, there are already available mechanisms. For example, the case of Uganda, we have quite a number where these tools, or most of the components from these tools, could be fitted. I'll think of the RH-PAS, which is periodically conducted by colleagues from pharmacy department. We believe that if the other component of commodity safety storage is included in the tool, part of the components of the tool, if not all, could be picked and included in the RH-PAS assessments. But also, as a country, we happen to have a project supported by government. This is a quality improvement project, which is looking at health facility assessments annually. Of course, at national level, it's conducted annually, but there is a provision for this tool that is placed at healthy facilities to allow health facilities conduct regular assessments at shorter time intervals, say quarterly. So I believe that the healthy facility quality assessment survey could be one of those mechanisms under which we can fit part of these components, if not all. But also we happen to have the harmonized health facility assessment, formerly known as SARA. This is a survey conducted by Ministry of Health with support from majorly WHO. It is majorly quality assessment and readiness to provide services at health facility level. So I believe that this RFS tool on quality fits very well in the harmonized health facility assessment survey tool. But also, I thought of the service delivery point survey supported by UNFPA in country, the biannual, whenever after 2 years. I believe this could be also another interesting opportunity for us to pick some of the components of quality to fit them into this tool. I think the last part of the question 3 may not apply since for part 2, I've responded in affirmative that we happen to have some data collection mechanisms where we can fit part of these tools or the entire tools. As I sum up, I'm looking at an opportunity where we could see both tools being abridged into one, because yes, quantitative surveys are good, but at one point you may need to get some insights that helps you to explain the numbers we're seeing or the scores we're seeing. But also I've noted that just like Dr. Jasmine, there are some components in RFS tool that are missing in the other DeFi tool and the same. So the teams sitting together to come up with a harmonized tool, I think it will be to the advantage of this team and to the group that is looking at advancing quality in FP. Thank you, and over to you, Dr. Emeka.
Thank you so much for being this concise with your response. We're coming close to the end of this panel, but just to reiterate and thank you for positioning that the issue and position of having limited options on what and how HIPs should be assessed have been cleared through this meeting yesterday and today. I hope we all share in this optimism that we can move forward with measuring what we're implementing around the HIPs. You did say that it would be useful, these tools, in assessing the components of commodity management and logistics at the community level, where the Ministry of Health have challenges in their programs, especially in storage of commodities. You talked about the use of standalone, use of these tools as standalone, which may pose implementation challenges because of the high cost of implementing surveys, and reason that the tools needs to be integrated into existing data collection mechanisms so that it will reduce the burden of collecting this data. And of course, you listed existing mechanisms in Uganda that these tools can fit into. For example, the improvement project, which is conducted annually by the Ministry of Health, the harmonized facility assessment that's conducted by Ministry of Health and supported by WHO, and another survey by UNFPA. And finally, you did say that harmonizing these tools, I mean, these RFOS and DFOI coming together to harmonize them will be very helpful in supporting country programs to implement them. Thank you for these very great insights. I know that the team will put them all together when we're coming out with the measurement framework for these HIPs. Thank you to Yasmin as well for being here. Thank you, everyone. We've come to the end of this panel. Back to Trinity. Thank you.
Thank you, Emeka. And thank you, Rogers and Jasmine. Agreed. Those were very helpful, concrete reflections on, again, the challenges and how some of these tools may need to be packaged and adjusted for different contexts, both different country contexts, but also for use by different individuals. So thank you for that. It sets us up very nicely for our discussions in the small groups. So that is what is up next. Next slide, please. We'll be breaking into groups to really continue this conversation. We would very much like to hear from you all, your thoughts and reactions to these tools. Do they seem useful? Do they seem feasible to apply in your context? What are the considerations that you would provide for how to use them? So we'll be randomly breaking into groups. Many of you have already done this, but if you would like to be in either a French or Portuguese group, if you could just put your name and either FRE or PORT in the chat, then we can make sure that you get into that correct group. Otherwise, we have designated facilitators and note takers who will guide us through the discussion, capture some notes on slides, and we will be reporting out at the end very rapidly. Each group will share one key discussion point or decision. So with that, I will ask Sarah to divide us up into those groups. And we will have until 11:20 when we will reconvene for that report out. So thank you very much and enjoy the discussion. Emily, we can go to the next slide. And then there may be one after that. I can't remember. But anyway, welcome back, everybody. Hopefully you had sufficient time to talk in your groups. And we have now arrived at the report out. So this is a very rapid style report out. Hopefully each of your groups were able to decide on one key point, one pearl. So I'm going to switch things up today, the order, and I would like to ask the Francophone group if you all would like to share your one key point or takeaway. So that would be Dr. Boukma or maybe JC.
Dr. Boukma, vous voulez y aller?
Oui, bonsoir et merci à tout le groupe francophone parcourir les différentes questions. On retient vraiment la numérisation des données par les ASVC et vu les contextes, on allait dire, à défi sécuritaire. Et encore, ce sera des données pas comme on va renforcer outre la formation, la supervision pour les amener vraiment à s'habiter. Au niveau du Burkina, le processus est en cours. et nous voyons que c'est vraiment pertinent. Donc, c'est le point vraiment qu'on a retenu. Sinon, dans les aspects, on en a parlé un peu au niveau des AS. Chez nous, il y a les ASBC et il y a les ASC qui sont qui animent la santé communautaire au niveau du village. Et il faut savoir que bon, ces agents communautaires sont formés, supervisés à le mentorat et l'évaluation. Et aussi, au niveau cascade, ils sont suivis à les infirmiers chefs de poste, les responsables de maternité. Ça remonte, c'est vraiment les districts sanitaires, les régions sanitaires. Donc, nous voulons aussi, il y a les aspects satisfaction des clients et aussi le counseling, mais ce n'est pas vraiment de façon sur papier que ces informations peuvent être retrouvées. Donc, on va travailler et voir comment on pourrait aussi relater cela dans les fiches de rapport. Voilà ce que, de façon rapide, ramasser les travaux du groupe francophone. Merci.
Merci, Dr. Bougma. Thank you for that. Maybe next I will go to the group that talked about other dimensions of quality. So thinking a little outside the main topic for today. So that is Erica.
Hi, everyone. So we wanted to highlight a gap, a pretty big gap that we discuss. This is in terms of assessing outcomes for both community health workers and pharmacies and drug shops, is that both are often missed or not fully incorporated into the existing health information systems. Community health information systems aren't often present or strong, and private facilities like pharmacies often aren't feeding into existing information systems. So this makes it hard to assess these pathways of care in ways that we can more easily assess in public facilities.
Thank you. And then last but not least, the group that was talking about the two tools that have been developed to measure the quality of HIP implementation. I think that is over to Alexis.
Yeah, thank you, Trinity. We had a rich discussion, and I'll share briefly about, we spoke about what would be needed to use these tools in your own context, and we had people from quite a few different countries, which was great. So we spoke a bit about how standardized tools would be helpful, but that they would need to be adapted to each country context, and ideally would be integrated into existing tools so that not so many different tools were needed. And then that the tools should either be available paper-based, which was spoken about for Uganda, because web-based ones can't be used at all levels, and that if they are digital tools, they should be available online and offline, and that yes, that tools should be integrated with existing ones, I think I mentioned. Yeah, so thank you.
Awesome. All right, a lot of familiar themes then throughout the day in terms of contextualization, integration into existing platforms, and questions around sustainability. So thank you, everybody. This was really helpful. As you saw, we recorded these because we'd like to take these inputs to help, at least in the case of the quantitative point of service survey, help us package and tailor that and then make it available in the ways that will be the most useful to everybody. So with that, I will be inviting Dr. Rita Cabra, who is the technical officer at the World Health Organization, to close us out. Rita.
Right, thank you so much, Trinity. Can you hear me?
We can.
Okay, great. So I think this was a great workshop. I would call it a workshop or a webinar come workshop, where we heard a lot about the importance of measuring quality. So this was really great, and I think all of us understood the importance of measuring quality. I think it's really, really important because of the work we are doing. If the clients are not satisfied, they will not use it. So we really think quality of care and family planning is really important, and we need to work more on quality than quantity. And all the tools which were mentioned today were also really very important. And I think they were already, the message is conveyed that how we can integrate it within the existing system. So that was great. It was a great workshop. I would really like to thank all of you for organizing this, especially to Trinity to organize this. To our colleague from Burkina Faso, Ministry of Health, Dr. Robert, thank you so much for opening the meeting. Nikki from UNFPA, Suzanne from D4I, Aurelie from R4S for presenting the work they have been doing, which was really great. And then we had a great panel session, which was, I think, organized by, who was it? Emeka. Emeka organized it. And then we have colleagues from Uganda and Nepal who presented their experiences. So I think overall it was really good. I wish you all the best, and I see how we can work forward, use these tools, and ensure that they or some aspects of this are well integrated within the system, which is actually measuring, which is collecting information, and that they start collecting information on quality. I think that is very important because, as I said, quality is more important than quantity. And we are often going on number and not taking care of it. Thank you so much. Over to you, Trinity.
Thank you, Rita, and thank you all for sticking with us, especially those who attended yesterday. We will be sharing out the links to the recording and some additional supplemental materials. So look out for those. Those will come in the near future. And then in general, we will be communicating out to you all when these tools, particularly the point of service tool, are finalized and ready and available for use. So stay tuned. Thank you so much. We really appreciate your active participation and attentive listening, and a big thank you also to all of the organizers and contributors. So thank you so much and have a good rest of your day.